When most people hear OCD or obsessive compulsive disorder, they picture something specific: someone washing their hands until the skin cracks and bleeds, checking the locks over and over before they can leave the house, arranging objects in precise symmetrical order. And OCD can look like that, but it does not always announce itself that clearly. Sometimes it looks like a thought that enters your mind uninvited and you can't shake it no matter how hard you try. Sometimes it looks like spending hours trapped in the same loop of worry, circling the same fear until you're just exhausted and still haven't found relief. Sometimes it looks like a ritual that feels completely irrational to part of you, but also completely necessary to another part of you, like having to dress your newborn in exactly the same order every single time. And if anything interrupts the sequence, you have to start from the beginning. It's time consuming, and you know rationally probably nothing bad will happen if you don't start over, but that small voice that keeps asking, what if, keeps nagging at you. It's exhausting. For many women, particularly during pregnancy and the postpartum period, OCD shows up through intrusive thoughts, unwanted, sometimes disturbing images that arrive without warning and that you would give anything to unsee or stop imagining. Thoughts of harm coming to your baby, not because you want that, but because you're so terrified of it that you can't stop your mind from going there and trying to prevent it. And most women never tell anyone because they're afraid of what it would mean if they did. Today, we're talking about perinatal OCD, what it is, why it happens, and why it's not what you fear it is. And most importantly, why getting help sooner rather than later matters enormously. I'm Dr. Susan Zink, a reproductive psychiatrist and specialist in perinatal OCD. OCD, or obsessive compulsive disorder, is a recognized psychiatric condition defined by the presence of obsessions, compulsions, or both. You don't have to have both obsessions and compulsions, though. It can just be one or the other. Current, persistent, unwanted thoughts, urges, or images that cause significant anxiety or distress. Crucially, the person experiencing them recognizes them as unwanted. They are not pleasurable, and they are not in keeping with the person's actual values or wishes. The person typically makes repeated efforts to suppress or neutralize these thoughts, either by pushing them out of mind or by performing a specific behavior in response to the thought. That behavior can temporarily calm the obsession, but the relief doesn't last. It starts over again and the loop continues. Compulsions are repetitive behaviors or mental acts such as checking, counting, cleaning, praying, or seeking reassurance. A person feels driven to perform these in response to an obsession or according to rules that must be applied rigidly. Compulsions are performed in an attempt to prevent a feared outcome or to reduce distress. They provide temporary relief, but the anxiety always returns, and often it's stronger than before. Over time, the compulsions almost take on a life of their own, consuming more and more time and energy. According to the DSM-5, which is our Diagnostic Manual of Psychiatric Conditions, a diagnosis of OCD requires the presence of obsessions, compulsions, or both. The obsessions or compulsions are time-consuming, taking more than an hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The symptoms are not attributable to substances or another medical condition, and they're not better explained by another mental disorder. And remember, you don't need to have both obsessions and compulsions to meet criteria. Some people have primarily obsessional OCD with little or no outward compulsive behavior, and this is one reason it often goes unrecognized. There's nothing visible to identify it from the outside. OCD is also frequently misunderstood as a personality trait, being so OCD about cleanliness or organization. But clinical OCD is not about being particular or tidy. Sometimes OCD manifests as excessive cleaning because of a germ phobia, for example, but this is only one type. And being tidy and orderly doesn't necessarily mean a person has OCD. Obsessive compulsive disorder is a condition that causes genuine suffering and really interferes with daily life. Pregnant and postpartum women are at elevated risk for developing OCD, and women who had OCD before pregnancy face a higher risk of symptom recurrence or worsening during this time. Research estimates that perinatal OCD affects approximately 1 to 2% of pregnant and postpartum women, although it may be higher because a lot of pregnancy and postpartum women don't talk about their symptoms openly. And we'll talk about why that is. The hormonal upheaval of the perinatal period, combined with the enormous psychological weight of new parenthood and the intensity of caring for a vulnerable new life, creates conditions in which OCD can emerge or intensify. During and after pregnancy, OCD obsessions tend to center on the baby. Common fears involve the baby being harmed, becoming seriously ill, or being taken away, for example. Compulsions typically involve checking on the baby repeatedly, seeking reassurance from partners and healthcare providers, or avoiding any situation that triggers the fear. The most isolating feature of postpartum OCD, and the one that keeps women from getting help the longest, is intrusive thoughts. These are unwanted mental images, often of harm coming to the baby. A new mother might find herself unable to stop imagining dropping her baby down the stairs, for example, despite the fact that the very idea horrifies her. She might begin avoiding the stairs entirely or asking her partner to carry the baby, really unable to explain why without revealing the thought she's terrified to speak aloud. Some intrusive thoughts are even more disturbing than that, and the harder she tries to push them away, the more persistently they tend to return. The shame is often enormous. The isolation can be profound, and many women go months, sometimes much longer, without telling a single person, including their doctor. But this is the important part. These thoughts do not make you a bad mother. They do not mean you will act on them. Their presence is often a symptom of OCD, not a reflection of who you are or what you want. In fact, they are exactly the opposite of what you want. They are really your worst fear, and the distress is born from taking great pains to avoid that fear from becoming a reality. The severity of perinatal OCD exists on a spectrum. Occasional intrusive thoughts are actually quite common in new parents and are not in themselves cause for alarm, especially if the thoughts are only occasional or easy to dismiss. What distinguishes perinatal OCD is the frequency and persistence of those thoughts, the significant distress they cause, and the degree to which compulsions and avoidance begin interfering with daily life. Sleep, bonding with the baby, relationships, and functioning can be affected. One of the most important things I can tell you in this entire video is this: perinatal OCD is not postpartum psychosis, and understanding the difference is often what finally allows a woman to reach out for help. Many women with severe intrusive thoughts are terrified that the thoughts mean they might be dangerous. That fear that they will be judged, reported, or even have their baby taken away keeps them suffering in silence for far too long. Postpartum psychosis is a rare but serious psychiatric emergency that affects approximately 0.1% of new mothers. It typically emerges very rapidly, often within the first 2 weeks after delivery. And it can involve thoughts related to harming the baby, but the nature of those thoughts is fundamentally different from the nature of the thoughts in OCD. In postpartum psychosis, a mother may feel commanded or compelled to act on those thoughts because of hallucinations, such as hearing a voice giving instructions, or because of fixed false beliefs called delusions, such as believing her baby has been possessed or replaced. Postpartum psychosis is also often accompanied by other unmistakable signs of acute psychiatric crisis, like severe sleep deprivation, dramatically elevated or erratic energy, disorganized or incoherent speech, and bizarre behavior. Women with postpartum psychosis lose touch with reality. Postpartum psychosis is a medical emergency and requires immediate care. So if you or someone you know is showing these signs, please go to the nearest emergency room or call 988. Perinatal OCD looks entirely different. In OCD, the mother is horrified by her intrusive thoughts. She has not lost touch with reality. In fact, she is so alarmed by these thoughts that she goes to extraordinary lengths to make sure they never come true. She avoids situations. She creates rituals. She checks and checks again. She is not a risk to her baby. Perinatal OCD is not associated with an increased risk of violent acts toward the baby. Often, a reproductive psychiatrist is the first clinician to ask directly about intrusive thoughts. Many women describe that moment as an enormous relief, being told by a knowledgeable physician that these thoughts are common, that they do not make you a bad mother, and that having a frightening thought does not mean you will act on it. That can be genuinely transformative and healing. Perinatal OCD doesn't usually resolve on its own, but it is highly treatable, and early intervention leads to better outcomes, fewer complications, and a shorter period of suffering. The gold standard psychotherapy for OCD is exposure and response prevention, or ERP. It works by gradually and systematically exposing the person to the thoughts or imagined situations that trigger anxiety while calming the compulsive response. Over time, the brain learns that the feared outcome does not require the ritual to prevent it, and anxiety begins to decrease. ERP is typically combined with cognitive behavioral therapy, or CBT, which addresses the thought patterns that maintain the OCD cycle. ERP usually requires working with a therapist specifically trained in OCD treatment. This is not the same as general talk therapy, and not all therapists are trained in it. It is worth seeking out someone with specific OCD expertise. In addition to therapy, we also have medications. SSRIs, or selective serotonin reuptake inhibitors, are the first-line medication treatment for OCD. This includes medications like sertraline, fluoxetine, and escitalopram, among others. It's worth knowing that OCD often requires higher doses than those typically used for depression or generalized anxiety, and some patients require more than one medication depending on symptom severity. For women who are pregnant or breastfeeding, there is a substantial body of reassuring safety data supporting SSRI use during the prenatal period. For many women, the risks of leaving OCD untreated, the suffering, the avoidance, the impact on bonding and relationships significantly outweigh the risks of medication. This is a nuanced conversation that deserves individualized attention, and it is one that a reproductive psychiatrist is specifically trained to have. The combination of medication and psychotherapy is the most effective treatment, especially for moderate to severe symptoms. Medication and therapy build on each other. It's also important to remember that OCD thrives on isolation and shame. Involving a trusted support person, a partner, a close friend, a family member who understands what is happening can be a meaningful part of recovery. Anyone else's problem to fix, but because shame loses some of its power when you're no longer carrying it alone. If any part of this video resonated with you, if you recognized your own experience in what we talked about, I want you to know what you're going through has a name. It has a biological basis. It is not a reflection of who you are or what kind of mother you are, and it responds well to treatment. You don't have to keep carrying this alone. You deserve support from someone who understands what you're going through and can offer real, evidence-based care without judgment. Next week, I'm talking about postpartum depression, specifically how to tell the difference between the baby blues and something that needs treatment. Subscribe so you don't miss it, and if this video helped you, please share it, because there are women in your life who may need to hear this too. I'll see you next week.